welcome to tonight's Gulf Society Cardiac Surgery Perfusion Working Group webinar. My name is Hassan Al-Shehri. I'm honored to be moderator for this webinar. Our focus this evening is highly vital modern cardiac surgery, the pattern of integrated perfusion platform. To guide this tonight topic, we are privileged to have highly esteemed international colleague, our speaker, Mr. George Steeson, joining us from Colorado, Denver, Colorado, in the United States. Certified cardiac perfusion, and we are excited to hear from him. Following the presentation, we will open up panel discussion and question answering. Joining us tonight, an outstanding panel of regional experts, Mr. Ijaz from Qatar, and Ms. Maria Al-Blushi from Oman, and Mr. Yusuf Shaddad from Bahrain. Thank you for being here. A quick note for audience, please. Type all your question after into the question answering box. At the end of this presentation, or at the end of discussion, we'll address as many as possible during the discussion. Without further delay, Mr. George, the mic for you.
Thank you all very much for the honor to be here with you today and be part of this meeting. And thank you for the invitation to all of the organizers and panelists. So today, what I would like to discuss is the benefits of an integrated perfusion platform and share with you a little bit about our journey at the University of Colorado in Denver, Colorado, and our experience with the Spectrum platform and how we have used that platform to enhance patient safety, outcome, and staff training. So our guidelines, our objectives today are to define what is an integrated perfusion platform and to explain our journey that uses continuous data to improve perfusion with real-time data integration and how this helps to reduce clinical variation in perfusion practice. So to get started, a little bit about our program. The University of Colorado Hospital is 800 plus beds. We're the only adult academic medical center in the region, and we perform 2,000 plus procedures annually. Some things that are unique about our program is we have a very large aortic surgery program. So about a third or 30% of our cases are aortic surgery. We also have a very rapidly growing minimally invasive valve surgery program. Transplants, which have increased by about 30% over the last 2 years, plus a very large ancillary practice. And by ancillary practice, I include procedures such as HIPEC, angiovac, other non-cardiopulmonary bypass procedures. We are an ELSO Gold Certified ECMO program. Last year, we did 147 adult ECMOs, and we have a team of 30 ECMO specialists who assist the perfusionists in that. And currently, we have 15 perfusionists that provide round-the-clock support to the program. I think the other thing that is important to know about our staff is much like cardiac surgeons in the United States, U.S. perfusionists are kind of going through a transformation right now as a lot of perfusionists from my generation, 80s and 90s, when we entered the field, are now starting to retire. So we're starting to see a large influx of newer, younger, less experienced perfusionists entering the field to replace all of us senior perfusionists. So I think that's also an important distinction to make when we talk about the value of an integrated platform. So at the University of Colorado, we use Spectrum in many different applications. We'll talk a little bit about extracorporeal life support, our use of the quantum heart-lung machine, but also how Spectrum disposables are being integrated into our practice as well. But the main focus of our discussion this evening will be informatics and how the use of data really is transformational in our program. So let's start a little bit with the quantum integrated perfusion hardware solutions and how we've utilized those at the University of Colorado. So our journey with Spectrum really began around ECMO platform. So this is a picture of our previous ECMO platform, which used to be primarily LivaNova SCPC. And then, as many of you know, we got end-of-life letters from LivaNova saying they would no longer support that platform. And so really our journey began by looking for a replacement for our ECMO system. We did have some secondary CentraMag platforms that we used to use for ventricular assist devices, mainly right heart ventricular assist devices, but we didn't really find that platform to be feature rich enough for us to use in our ECMO practice. So there were some very important things or elements to the Spectrum platform that helped convince us that that was the right hardware platform that we wanted to go to for ECMO. First was the CP22, or the centrifugal pump used in the ECLS platform. Some features that were important to us is it allowed us to have pressure inlet regulation or negative inlet pressure regulation, which we thought was a very important safety feature. It also allowed us to reduce circuit intervention and better performance and safety, especially as we were making this transition from primarily having perfusionists be the bedside monitors of ECMO to the ECMO specialist. So we also more value than the CentraMag from a pricing and from a supply chain management. And it allowed us to have oxygenator supply options. So by going with this platform, we weren't tied to a particular pump oxygenator manufacturer like some other platforms do. The second thing that was important to us was the ventilation module that gave us improved gas management. It gave us safety by having redundancy of operating controls, and it allowed us exhaust gas analysis, which is very important in getting metabolic markers such as carbon dioxide transfer, oxygen transfer, etc. But most importantly, again, is the workstation, which allowed us to have a continuous electronic record for ECMO, which integrates with Epic, our hospital's electronic health record platform, but also provide clinical decision support. And I'll show you some examples of those features later here in the presentation. So one of the advantages of a single Spectrum platform for ECLS was it allowed us to have a common platform now for multiple applications. So not only did we have a common hardware platform for bedside ECMO, but that same platform could be used for right ventricular assist or RVAD. It can be used for ECMO transport. And very important in our practice is normothermic regional perfusion, or NRP, which you may know is become a very explosive growth area in the United States in transplant medicine, and allows us to have the same hardware platform. So used to increase our availability of deceased cardiac death transplant organ donation. Matter of fact, this is a very important aspect in transplant medicine in the United States. This is some data which we just published this year in Clinical Transplant. And this looks at the rapid growth of NRP and DCD in the United States. And what this chart shows is a 30-day rolling count from 2015 to 2025 of the growth of donation from brain death versus donation from cardiac death. And you can see how rapidly in the last 10 years DCD has grown. And matter of fact, last year, between the May-June time period of 2025, DCD has now exceeded DBD as the method of organ donation. And so it's now becoming the primary pathway for organ recovery in the United States. And so NRP is a very important tool in supporting that rapid growth. So one of the advantages that we have with the Spectrum platform was it allowed us to not only support NRP, and here you can see an example of our NRP circuit. We see the Spectrum workstation. We see a traditional hard shell oxygenator reservoir system, centrifugal pump. So not only for the primary resuscitation of the donor, but it also allows us to add a secondary pump, a roller pump, which we can use for such things as cardiotomy suction, direct active ventricle venting, and also delivery of preservation solutions in situations that we call heart rapid recovery. And so all of this equipment can collapse into Pelican travel cases and be transported to any location in the United States that we go for organ retrieval. More importantly, the workstation gives us, again, a common electronic record platform, which we can now integrate back into Epic so that we have a continuous record for the transplant recipient of the quality of the organ recovery, and allows us to, again, implement some potential best practices. So let's talk a little bit about the quantum heart-lung machine. So now we're here. We have established Spectrum in our program as our extracorporeal life support platform, using it for ventricular assist, ECMO, NRP, other applications. And it has now become time in our practice to think about replacing our aging fleet of heart-lung machines. And so our institution has been very active in studying, researching, and utilizing goal-directed perfusion. And so we were early users of Connect and the S5 LivaNova hardware platform, mainly because we believe that goal-directed perfusion is more than just talking about a targeted oxygen delivery. In order to be really patient-specific or to have a customized, unique oxygen delivery target for each patient, it needs to be metabolically based. So you need those other goal-directed perfusion markers of patient metabolism, such as oxygen consumption index, carbon dioxide production index, and those various ratios of those elements along with oxygen delivery. So Connect was our platform that we had used in the past, but again, those were becoming end of life. And so we looked at the new Essence platform and compared that to Spectrum, but we found some limitations for us in our practice with that platform. Mainly that had multiple control interfaces that you needed. It had a monochromatic graphic user interface, which was not preferred by a lot of places. But most importantly, it still required us to use a third party or external analyzer for carbon dioxide production or for exhaust gas capnography. So you can see here, we still required us to use the VAMOS capnography, and it also still required us to have a non-integrated or manual vacuum assist regulator. So the platform that we chose was the Spectrum New York frame. We liked that because it was a familiar footprint and it helped us to reduce congestion in our circuit. And more importantly, it provided us with a familiar graphic user interface structure with the ECLS. So now we have a heart-lung machine hardware platform that had the same structure and the same software interface for alarm management, for all of our safety systems, which allowed for more rapid adoption and reduced the staff training time. So it's everything that LivaNova used to be for us, but more because of this element of it, and that's the ventilation module. So the ventilation module, I feel, is a differentiating factor for institutions who are really interested in goal-directed perfusion. There's really no other option on the market today for integrated exhaust gas capnography other than sharing that that analysis with anesthesia machines. And it gave us the critical carbon dioxide production values that we were looking for in a heart-lung machine. So the other kind of surprises for us, or things that we have determined to be critical in our practice, are some things that we didn't even know that we needed. And I'll say the first one of those for us in the Spectrum platform was the arterial and venous occluders, which you see here highlighted. And the arterial and venous occluders added safety, added precision, but more importantly, allowed us automation of many portions of cardiopulmonary bypass management. It helped us increase our utilization of things like retrograde autologous priming, and then the built-in automated features of initiation mode and weaning mode helped to reduce staff variation in practice, gave us more precise volume management, and it helped us improve the hemodynamics of the patient during the initiation and weaning mode. So when you have a young team like myself, we're 15 perfusionists, but 60% of that team is less than 3 years of experience. Having a device like the occluders integrated into these automation processes really is what I call an experience equalizer. And so it allowed both experienced perfusionists and less experienced perfusionists go through these critical transitions of bypass initiation and weaning seamlessly or identical to each other. And so that reduce that experience bias that you may see in a team with diverse experience ranges. And here's just an example of this. When we started autologous priming or the automated autologous priming, our baseline rapitents were less than 40% of cases. So less than 40% were we doing an autologous prime at the beginning of the case. And so the spectrum occluders allowed us more control on the rate of RAP, help reduce the hemodynamic derangement. And so we had less dependence on anesthesia for support because the perfusionists had better control. And we got better compliance from skeptical staff on the effectiveness of autologous priming. And so as a result, our autologous priming has moved now from 40% of cases to more than 66% of the cases in less than a 6-month time period. The initiation mode helps us to reduce the hemodynamic collapse at the beginning of bypass because we can now program a very specific flow rate that we initiate bypass at over a specific time period. So it allows for a more controlled transition from patient's cardiac output support to the heart-lung machine. So as a result, we see more stable mean arterial pressure, reduced vasopressor use, and reduced variation in NIRS. As a matter of fact, you can see in the pre-bypass period here where there was a lot of cyclical nature in the mean arterial pressure. This is during the anesthesia support prior to bypass to a much more stable initiation and cardiopulmonary bypass. The other thing that we have that we didn't know that we needed was this anesthetic gas analyzer. So this looks at the level of volatile anesthetic, isoflurane in our case, coming out of the vaporizer. So now we have not only electronic documentation of the anesthetic gas going to the oxygenator, in addition to the MAC analysis from the exhaust gas. And so used in conjunction, it allows us to ensure that we really have an appropriate level of anesthesia to ensure lack of awareness, but it also helps us troubleshoot uptake problems, which we often saw in specific types of oxygenators or in cases where we were maybe utilizing pH stat blood gas management instead of alpha stat. And so I think these are an important safety element that should be standard on every quantum heart-lung machine. So how has the quantum heart-lung machine impacted our understanding of goal-directed perfusion and our application of goal-directed perfusion? We know right over the past more than a decade now that monitoring critical oxygen delivery is very important to patient outcomes, in particular to reducing the rates of stage 1 acute kidney injury. But we still have many problems with microvascular dysfunction. And so this is one of the things that we are studying currently at the University of Colorado, looking at the effect of reduced perfused capillary density and glycocalyx thickness during cardiopulmonary bypass. We see in patients who have acute kidney injury that there is a continuous decrease in the glycocalyx thickness, not only in the pre-bypass period, but specifically in cardiopulmonary bypass. One of the theoretical things that we're researching right now is the effect of pulsatile flow on helping to mitigate that rate of glycocalyx dysfunction or thinness, and also a more rapid response, the glycocalyx or the endothelium post bypass. And so the Spectrum heart-lung machine is the only new heart-lung machine on the market that allows us to do pulsatile flow. So this is one of the current active areas of research that we have going on in our institution. And so we think that combined with other mechanisms to help preserve endothelial function and thickness may have some additional benefits, reducing the deleterious effects of cardiopulmonary bypass. So could there be a joint benefit that and combined with physiological perfusion? We think so. So this is a picture of the Spectrum hybrid system on our heart-lung machine. So this is the Spectrum hybrid reservoir, which allows us to have separation of pump suction blood from vent and venous return. That helps us to allow secondary processing of cardiotomy suction blood. It also helps us to reduce gaseous microemboli, which can protect the endothelium and reduce the glycocalyx thinning. It also helps us to reduce the blood-air interface in the foreign surface area contact because of blood being stored in a collapsible venous reservoir, not in a traditional hard shell with exposure to the large filtering area. And so physiologic oxygenation along with the hybrid reservoir can help us to avoid vasoconstriction as well. So we all know that hyperoxic vasoconstriction occurs. We see this from this meta-analysis published in 2018 that looks at the change in systemic vascular resistance in patients that are exposed to high arterial PO2s. So this systemic shunting occurs. We see it globally expressed on bypass as an increase in the respiratory quotient or more carbon dioxide production compared to oxygen consumption. And we see it as decreased oxygen extraction. We also know that hyperoxia can be associated with a link to increased acute kidney injury. Even though the renal medullary layer is sensitive to low DO2, there is this time-weighted risk of exposure to high arterial PO2s and increased acute kidney injury. So this combination of a hybrid reservoir, hypobaric oxygenation may be beneficial in those respects as far as having better perfused capillary density and decreasing the AKI risk. The other potential benefit to hypobaric oxygenation is the removal of gaseous microemboli through denitrogenation of the arterial blood. This is a small pilot study that we did with hypobaric oxygenation compared to a control group where we did a 4-to-1 match. And these were largely open cases, aortic and valve cases, open mitral valve repair cases, a few CABGs in there. And what we were looking for in this case was, did hypobaric oxygenation not only decrease the GME coming from the extracorporeal circuit, but did it also help reduce or help mitigate intracardiac air or surgical air? And so we had 5 blinded panelists who reviewed TEEs from both the control group and the hypobaric group, and they scored these TEEs based on the amount of air that they saw in the left ventricle and aortic root after removal of the cross clamp. Here's an example of those TEEs. The one on the left is an example of case with no air present. The one on the right is moderate air present. And so they ranked the amount of air that they saw on a scale from 0 to 5. And certainly what we saw in the hypobaric group was a reduction in cases where there was any air, as well as a reduction in cases with severe air. And in fact, in the hypobaric group, there were no cases that were ranked 3, 4, and 5 in the CABG or mitral valve repair group. So some potential benefits there as well with hypobaric. And so those are some examples of how spectrum disposables are helping us to mitigate some deleterious effects from GME and hyperoxia. So more importantly, what I want to talk about in this presentation is the value of informatics, or the value of having a continuous electronic integrated record, and how you can turn that data into knowledge and some practical ways to help improve the performance of your perfusion team. So oftentimes when we think of quality improvement, I look at it as two types of buckets. And you can kind of make the analogy to technology that you might see in modern cars, right? We have real-time technologies, such things as lane departure avoidance and correcting your car steering automatically to keep you centered in the lane, right? So those are reducing variation or excursions in real time, versus what we would traditionally think of in quality improvement, and that is just a summation of your cardiopulmonary bypass experience. So early electronic charting adoption, this is something that I've been very passionate about in my career. This is one of my first publications from 1987, and even back then, we documented that in patients or where we had an electronic perfusion record, that we reduced the time between documented events. We had a more detailed description of bypass, and it helped to reduce the variation in our documentation. So we have a long experience in using electronic records and the value of those in our perfusion practice. So that was, I think, probably the center point or the kingpin of our entire perfusion experience with Spectrum, and that is the Viper informatics. And so the Viper informatics allows us to collect real-time perfusion data from a variety of platforms: our heart-lung machine, our NRP experience, ECMO, all going into an informatics server, where then we can do things like live remote monitoring, real-time dashboards, quality reports, and analytics, but also integrate it with our hospital electronic medical record platform, Epic, to create unique records for bypass and all the ancillary procedures as well. So what do we define, or how do we define an integrated perfusion platform? Well, the value of it to us is it's a single source of truth. So a unified record from various sources helps to eliminate duplicate or conflicting documentation across maybe siloed systems. If you're using paper or electronic or different record systems for different types of cardiopulmonary bypass applications. Integration to the bigger record allows cross-team access in real time. it's real-time data, right? So an average cardiopulmonary bypass case for us is more than 15,000 data points with 200 plus unique perfusion variables that are logged with timestamp precision. It allows us real-time and quarterly benchmarking. It links preoperative, intraoperative, and postoperative data together in one location and tracks multiple perfusion practice domains. In addition, it allows for closed loop documentation, which adds another layer of patient safety because we have built-in checklists that send automated alerts and deviations from practice, and it allows for a closed loop audit trail that supports accreditation, legal, quality improvement review. So our goals with informatics are to link perfusion management to an outcome, whether it's acute kidney injury, delirium, length of stay. It helps us to reduce variation in practice because it helps new perfusionists perfect their practice and not be overwhelmed with just the task of running cardiopulmonary bypass. And it helps with the experienced perfusionist to remove experience bias, right? To remove those thoughts of, well, I've always done it this way and it's always worked this way. So data assimilation allows you to link these complex data points to these outcomes. More importantly, data integration really helps to reduce the staff training burden. And it does this in several ways. First of all, it helps to standardize workflow. So a single integrated platform enforces consistent documentation protocols. So there's uniform charting between all practitioners, and you can build in protocol adherence into the system so that they're not relying on memory of what is a particular protocol or how to apply a protocol. You have a direct and automated data capture so that staff can be trained on managing outcomes, not on transcription mechanics. And it is a unified interface. So there's one system to learn. So there's one system to learn for ECMO, NRP, VAD, cardiopulmonary bypass, and that helps to reduce onboarding time and reduce the cognitive load. So new perfusionists reach proficiency faster with a single cohesive platform, and there's fewer context switches between software, helps to reduce fatigue and error rates. So built-in safety checklists help to guide staff through best practice protocols without memorization. And we'll look at how we use some of those built-in safety checklists and best practice protocols that are provided in the Spectrum Viper platform. This is important in a program like ours. So this is a team familiarity matrix at our hospital. And so what this is looking at was 10 perfusionists who work with 7 cardiac surgeons and 15 cardiac anesthesia. And so you would think that we all know each other, and we do all know each other very intimately. But when you look at the number of times in just one quarter, so in 3 months, the number of times that the combination of these teams work together, you can see that there's a lot of ones. There's a lot of single times when those teams actually came together. And max, the highest was 4. There's a few 3s, a few 2s in there, but amazingly, with this, as your team expands, the team interaction actually decreases. And we know that that team interaction has impacts on patient outcome and adds time to cardiopulmonary bypass. So this is data from a multi-institution study that we participated in here in the United States. This was led from the team at the University of Michigan. And what you see on the left here is a plot of how many times or what the percentage of times that teams were familiar or worked together. And the peak is around 8. So 8 times in a quarter was the highest frequency. But you can see there's a lot of teams like ours that are here in the low team familiarity, where you maybe only work together 1 to 5 times. And we know that that has an impact on the perfusion time, the team familiarity, especially in high risk cases, which is this yellow bar here at the top. So clinical guidance is something that is built into the quantum informatics. And what clinical guidance does is it's predictive analytics that you build from your local protocols and your knowledge. And so it continuously monitors data in the background to look for critical thresholds, but also look for rates of change of parameters, things that are rapidly changing. And it provides an extra level of patient safety and helps to accelerate the clinical experience of younger team members. So one examples of these is what we call the Oxygenator Health Critical Care Score. And this is something that we use in ECMO. And what it does, it continuously tracks continuous data such as PaO2, PaCO2, as well as laboratory data, and calculates a value that tells you the health of the oxygenator. And so what it's doing in the background is essentially taking over the role for you, or assisting you in the role of monitoring oxygenator health and predicting potential oxygenator failure. And then what you see, what the clinician sees, this is an example of our live view dashboards. And so this is something that the clinicians can see at their workstations bedside, but also we can see it in the pump room. I can sit in my office and watch this. I can see every ECMO running, every VAD running, every heart-lung machine running. And so what we see on the bottom here are these critical care scores, but then you'll also see alerts pop up that tell us when a patient's out of compliance. Perhaps this is a patient that is starting to deteriorate and may require additional intervention or increased support. But then they'll also pop up clinical guidance, and they'll tell us things like, hey, you have an impending oxygenator failure, or you're having increasing hemolysis and clot burden in your circuit, and you should go and inspect this circuit or potentially plan an intervention. On the workstation, this is what the clinician sees. So you'll see these little boxes down here. Here's an example of an oxygenator critical care score, and you'll see a number. It can be anywhere from 0 to 100. And it will also change color as you reach critical stages. And so I call this my drive-by ECMO circuit check. So as I make rounds on patients and with staff members, I can very quickly get a sense if anything is happening with that circuit or with that patient that I might need to stop and investigate further. It can also do some unique things like help predict impending oxygenator failure. And so here's an example of that. This purple line is the pressure drop across the oxygenator. And in this case, you can see how it was slowly growing, but then suddenly there was this rapid increase in the pressure drop, and you can start to see some additional pump auto regulation because of this increase in clot burden. And so this can send an alert not only looking for long trends, but for immediate action or increased rate of change. So one of the other interesting things that we're starting to imply or utilize in the Spectrum platform is how we can integrate machine learning and goal-directed perfusion. This was an exercise in machine learning that we did. We took 5 years of GDP data, 2,058 cases of all types you'll see here, and ran them through an XGBoost machine learning exercise. And our machine learning algorithm was able to predict AKI with more than 99% accuracy. And what this machine learning exercise does is then it lists important elements in their ranking as far as their importance in predicting acute kidney injury. And so you can see in this experiment, our number one predicting agent was the total volume of packed red blood cells transfused. And then second was cardiopulmonary bypass autotransfusion volume. And then we see some of the goal-directed perfusion elements high in the list as well. The mean DO2, nadir DO2, the time the mean arterial pressure was less than 55, the mean DO2 VCO2 ratio. And so it looks at both preoperative, intraoperative, postoperative values and ranks them in importance. And so what we are able to do with that now is we are able to take all of these elements and build a critical care score into our electronic perfusion record that displays on the workstation. So instead of the perfusionist having to monitor 13 or so individual goal-directed perfusion elements, the software is monitoring those continuously and putting them into a cumulative score. And we can control not only the absolute values that go into calculating, but we can also control the shape. So, some of those values are linear relationships, and some of them are nonlinear relationships. And so you can shape the value curves based on the historical perspective of that data element in goal-directed perfusion. So it continuously monitors all of these elements. And then here's an example from what we call the gauge bar. So this is the top of the workstation on the quantum heart-lung machine, and this displays continuously no matter what page you're at in the workstation. So you'll see some traditional data, like cardiac index and flow, line pressures and temperatures, patient's mean arterial pressure, their systemic vascular resistance, as well as all of the goal-directed perfusion parameters. But you'll also see this GDP score. And so this GDP score is taking all these different elements that were identified in our machine learning exercise and rolling them into a continuous number that now the perfusionist just needs to look at that one number. And when that one number, that GDP score, starts to fall, then the software will highlight what is the parameter that is going out of range that you need to focus on. So it helps to reduce variation between staff, reduces the reaction time, and lowers the cognitive workload during the bypass. It also helps to equalize experience levels among the perfusion staff. And so indeed, what we saw after adoption of this was a reduction in variation. We saw a reduction in the DO2 area under the curve, or the time weighted variance in our oxygen delivery decreased. And we also saw a reduction in the average nadir DO2 excursion. So rather than a large excursion like we saw here in the first month, the variation between perfusionists got smaller and smaller. So it helps to avoid overcorrection and improve the reaction time, which limited the excursions. So in our GDP perfusion trip summary, what we see is related to an outcome in patients who got acute kidney injury. They had a lower GDP score, and their average minimum GDP score was lower than in patients who did not have acute kidney injury. But further, what we can see is in patients who got acute kidney injury, there was less time where our oxygen delivery was lower than our critical threshold. So it certainly helps us in mitigating excursions in our practice. And this is just a screenshot of how you set up those GDP scores in the Viper software. One of the other ways that we use this Viper software in our Spectrum platform is to help us reduce unnecessary packed red blood cell transfusion. So this is another algorithm that runs in the background. And our goal here is to have the right transfusion at the right time. So this algorithm defines a physiological need for additional oxygen delivery. It looks at the low absolute hemoglobin, and it also helps to define patients who have a high metabolic demand, such as elevated oxygen extraction or a low DO2 VCO2 ratio. And when those situations occur, then a checklist appears for the perfusionist that allows them then to identify or helps them walk through the logic of identifying what's going on with patient and whether the transfusion is appropriate, and keeps them in protocol alignment. And so as a result, we've reduced our transfusion bias from 22% to 3.6%. More importantly, I think this is probably one of the most important screens for us in the Spectrum Perfusion Viper platform, and that is the trending screen. And so this allows us to co-trend very important or interrelated parameters such as NIRS, which you see here on the top, mean arterial pressure, oxygen delivery, temperature, and the patient's PCO2. And so we can see the interrelationship of values that are important in predicting cerebral autoregulation zone. So in conclusion, how do we link training reduction to quality improvement? Well, in a fragmented environment, we have multiple siloed systems for documentation that a perfusionist has to master. And this can lead to inconsistent documentation, transcription errors, limited visibility into performance gaps for benchmarking, and it's a high burden for onboarding new perfusionists. Whereas an integrated platform has a single workflow, so there's less to learn, less to forget. You can embed standardized protocols into the system, and automated capture and real-time benchmarking are possible. So it helps to guide new staff by having built-in checklists, and it's more of a proactive, data-driven quality improvement tool. So thank you very much for allowing me to share our experience with you. And I will turn this back over to the moderators now for questions.
To invite our panelists, Mr. Yusuf Shaddad and Miss Maria and Mr. Ijaz. Please open your camera and microphone. Thank you. Now the discussion open.
Well, thank you so much. Thank you so much for the speaker, Mr. George. It was an excellent presentation. I think you highlighted very important points regarding integration, especially how these systems can, support perfusionists during complex and high workload situations. Um, I just have a question here. We have, recently introduced the quantum perfusion system in our center in Oman. I work at the National Heart Center. It is the main tertiary referral center for all cardiac cases. We do a big spectrum of patients from neonates to adults. From your experience, what are the most common challenges centers face during the early phase of implementing integrated perfusion platforms, and how can the perfusionists overcome them effectively?
Hmm. Well, that's a loaded question. I think there's several challenges in doing this. I think the first challenge that you have is you have to get widespread adoption or acceptance in your program from all aspects: surgeons, anesthesia, perfusion, hospital administration, that electronic record keeping and integration of diffusion electronic data into the bigger patient record is important if you're really interested in studying cause and effect on patient outcome, right? So I think a lot of times in many practices, what I see is perfusion is kind of a missing data element where we don't have resolution of data, right? We don't have enough detail in the data to say, oh, hey, maybe this is something affected by cardiopulmonary bypass, or maybe this is just background noise from the surgery itself, right? That's one of the things that we have learned in our journey in studying acute kidney injury, for example. There's a lot of pre-existing conditions in the patients. There's a lot of non-modifiable factors that impact their journey into developing acute kidney injury. And so you have to be able to sort those patient phenotypes out, like those who get early onset or what we would call a transient acute kidney injury versus those who are already on this projection to advance. So I think adoption that you need data is important. And then I think you have to implement that in stages to your team. It's not something that you can just turn on with a switch. You have to go through first getting familiar with the hardware platform. And we do that a lot through perfusion simulation. And then you have to slowly introduce first documentation. And then second, you have to do then the more advanced analytics. So all the kind of built-in software tools that it provides, you need to be introduce those in stages to the point where the perfusion team's not overwhelmed with trying to do too much too fast.
Thank you. Thank you so much, George.
Thank you so much, Mr. George. And I truly admire how you come from traditional generation of perfusion practice while still remaining highly enthusiastic about the innovation and adopting the modern technology in our field. That's really, it makes me like, I want to give more in our field, perfusion field, in the future. I got a lot of questions here, and also from my colleagues here in Bahrain. I got a couple of questions from an anesthetist, but I see here also we have audience, couple of questions. So I would rather go with the question from the audience. Then at the end of this discussion, I can ask like a couple of questions on behalf of my cardiac center here. So
Sure.
when Mr. Abdullah, he's asking, what is the real impact of combining the real-time monitoring, automation, and the data analytics into one perfusion ecosystem?
Well, I think the real value is, you know, when you start looking at electronic documentation in the intraoperative period, and I think the intraoperative period is very different than postoperative or preoperative. But intraoperative, we have a wealth of information available from the heart-lung machine, from the patient physiological monitors, from, secondary devices that you might have connected, for example, NIRS monitoring. And I think for the perfusionist, as you start to integrate multiple monitoring modalities, it gets a little overwhelming, right? It gets a very burdensome, especially for as you're training up younger perfusionists in their experience, right? They're focused on just providing safe cardiopulmonary bypass, right? Monitoring the venous reservoir and monitoring return and giving cardioplegia. And so it's easy for them to lose sight of these interrelated physiological variables that they're throwing in with them. And so I think that's the value of having these tools run in the background, is it doesn't relieve the burden of choosing what or how you want to intervene and manage that patient, but it allows you to have tighter control so that there's less time for variation, right? So one of the things we know in GDP today, more important than the actual oxygen delivery, is how much time do you spend below a threshold, right? So if we can come up with tools that give earlier alerts and warnings to people that, hey, you're falling below this threshold and you need to react quickly, right? So the average cumulative time for low oxygen delivery before it has an impact on your AKI rates is less than 15 minutes. And that's cumulative time during the case, right? So I think that's the value of having these, is as we start and find the interrelationship of all these values, it helps to keep you on track.
George, this is Ijaz Hidayat from Qatar, and we are using the Spectrum heart-lung machines since 6 months before, and we experience like this technology, especially for the auto winning mode and auto initiation mode, which is a really a fantastic advancement in Perfusion technology. My point is, like we in our center, we used to initiate mostly the ECMO patient, like the cardiopulmonary bypass procedures, like auto initiation mode and even the weaning mode. My question related to the auto weaning and auto initiation mode, how frequently have you experienced people are starting to using the initiation mode? Because it is something like a people like me and you, we are from the like a old age group, and we used with the manually to clamp and release, and we difficult to trust on the machines to open the clamps and clamping the venous. So have you experienced something like some disaster, someone explain, have given you some incidents, the time of initiation and even auto initiation, and even the time of the weaning of the bypass?
Sure. I've been a perfusionist for 43 years, and
Yeah.
it's been really hard to give up the tubing clamps, right? And let the machine do it. I'll say in our experience, people rapidly accepted and adopted the weaning mode. And so very quickly, we had 100% compliance in the weaning mode because people saw how much easier it was and how much more consistent the
Yeah, yeah.
process was. And the surgeons, I think, noticed that more than the initiation mode. It took some time to get people to accept the initiation mode, and we're still not there. It's still not 100% compliance.
Frankly, I'm interrupted. Frankly, even me, you to start with the auto initiations is I'm okay. But for the timing of the waning, I thought I will go with the manually. But then slowly, when we go with then and we'll start enjoying the like we are in an aircraft and we just give auto mode to wean and to initiation. It was very fantastically perfect.
Yeah, yeah, it is perfect. And I think what people are uh, concerned about in the initiation mode that is if things don't go well, how easy is it to get out of that mode? And it is pretty simple. It's just a push of a button, right? A single button, and you are out of the software and you take over control again. I think more importantly for us in the initiation mode, it was retraining the surgeons that taking that additional time to go on bypass was really beneficial to the patient, and it didn't really make that big of impact in the end of the day if we took a minute to go on bypass versus 10 or 15 seconds. So yeah, so I think that's the learning curve is not only for the perfusionist but
Yeah, yeah.
for the rest of the team.
Commenting on the auto initiation, our surgeons don't have patience. Like I set the timer at 30 seconds and he's asking me, is your venous line open yet? Is it open yet? I say, yeah,
Right.
it is open. It's just slowly draining the patient. We don't want to, suddenly empty the patient. So this is really challenging, but it takes time. And as George mentioned, we need to teach them more about the benefits of this feature.
Yeah, I think if you can show them how much more stable the pressure is, or maybe you're using less vasopressors at the initiation of bypass, and that has some value to the patient. Maybe
So
you
Let
George,
me
can work.
ask you, George, sorry, Jazz,
so carry on.
how much do you rely on the numbers you see in the monitor, the Spectrum Medical, the inline monitoring system?
Yeah.
Like, does it reduce the number of blood gases you do, and how accurate you see these values are?
So I think first thing regarding accuracy, because of the type of technology that Spectrum uses to determine those values, I think it's really important that you get a good initial calibration. And so that's something else that is, I think, unique. So the way we do that, the way I practice that is I go through my auto initiation mode, I get everything stable, and then I sit there at that point and get my initial calibration. So I'm not changing temperature. I'm not doing any other, adjustments to the bypass until I get that initial calibration. And so that's also a change in practice, right? People are used to crashing on pump, and then you immediately hit the heater cooler and you start cooling if that's part of your protocol. And so it makes getting that initial calibration less accurate because you have multiple parameters all changing at the same time, and you're trying to hit that one point where they
Mhm.
intersect. And so if you have the luxury of just taking a few more seconds to get that gas off and that initial calibration, then I think the results are much more reliable. it really hasn't changed the number of blood gases that we do during the case, because we're still doing the blood gas for other things, right? We need the other electrolytes, we need glucose, etc. But what it has done is helped reduce the excursions in the blood gases in between those discrete data points. And we really like the auto regulation feature, especially on the PO2.
There is just one input regarding to the parameters. Initially, when we initiate the bypass, so what we used to do when we do the first blood gases, so we try to synchronize with our blood gases which is present. We get it from the lab, and the one which we already displaying the parameter which is displaying on the spectrum inline monitors. So what we used, we practice. This is our routine practice as within 15 minutes we'll do the one blood gases like arterial, and even we do the venous blood gas also. Then we do the synchronize, and mostly then you will get the real numbers which we required according to the real from the blood gases which we required. George, I have one question. Sorry, I am giving you another question. Is not a question actually. This is something like what we noticed. Just this is humble things that what we experience, especially for the cardioplegia and the cardioplegia dual pump. Related to dual pump of the cardioplegia, the space of the cardioplegia pump is like big far. So if it is possible in the future, so you can make both dual pump near to each others, because the time you when we get to customize so the circuit of the cardioplegia circuit, so it's something look very so not ideally. So if it is possible in the future, the dual pump should be near the both pump, like a master and slave pump, should be near to each other. Is it in future if it can happen?
I'll ask you, what size roller pumps are you using for your master slave? Are you using
We are using 4 with the
6
ratio 1,
inch?
the routine cardioplegia circuit. So
Yeah.
usually, the pumps, there is a big gap in between master and slave. So we want like a positioning should be near to each other, as there is like a more gap in between. So it is fine, perfectly fine. But if it is be near to each other more, it will be ideal. Like if you see the previous machines having the dual
Yeah.
pump just near to each other.
Well, ours are near each other. I mean, right adjacent, like
Yeah,
they
yeah, yeah,
touch
yeah.
each other. And so maybe that's something that your Spectrum rep can help you with different mounting options
Yeah.
that they have. And so there are different clamps that you can use to mount them that will put them right next to each other.
This is true.
Okay, so George, I
Thank
got a
you.
question from one of my colleagues, is anesthetist. He's wondering if we could if there is an option to do integration between ECMO machine, if we are using quantum, with the ventilator, in a way like we could wean the patient off, and we have, for example, the clamping device. So is there an option to integrate it with the ventilator?
Yes, there is. And I didn't show you that detail, but back when we were looking at our live view dashboards, in there, you will see that there's not only all the ECMO data, but there's also the patient monitor and the ventilator data is all there as well on that same screen. And so you can monitor them simultaneously, and you can build critical care scores. For example, we have a ventilation critical care score that checks for things like making sure the ventilator is in resting lung settings, right? It looks at the PEEP and the pressure airways and the PF ratio and tidal volume. So you can link all those together.
And one more question, and got here. In an emergency situation, like how does the platform support the rapid clinical decision making?
I'm sorry I didn't.
An emergency situation, like how does the platform, because we
Yeah.
are not using this platform, the quantum,
Uh-huh.
so far. So how does it support the rapid clinical decision making, or like
Yeah. How does it support this real-time decision
yeah,
making?
because when you are practical, because we are doing all like handy things, so now all of a sudden if we are started to use the automation system, so
Yeah.
I think will be lag between the decision making or taking a real action.
Yeah. So the data is real time, right? We're collecting data every second, and so it's probably has a faster reaction time almost than human brain does, because it can take all these parameters every second, analyze them, and then send you an alert when it sees something that you set was out of range. So you can make it all customizable based on your own protocols. It's not pre-programmed limits. And yeah, so every second.
All right, and here from the audience, so Ms. Fatma was asking, how does the integrated perfusion platform help reduce the human error during long bypass procedures?
Yeah, so that's a great question because I think there's even more value to this in institutions like ourselves, right, that have longer bypass runs, right? We're an academic training facility, so all the physicians are residents, right, in training. And so we have some pretty long bypass times. And I think the value is it helps overcome that fatigue that perfusionists can develop. The other thing that's kind of unique in our practice is we do a lot of after hours cases, right? So a large percentage of our surgeries don't even start until after 3 o'clock in the afternoon. And so you're running pretty late into the evening. And we all know that time of surgery, you know, has been documented to increase your risk of a poor patient outcome. And so I think having these integrated uh, monitoring platforms help reduce that fatigue.
It's a great system, Yusuf. I don't know, you still don't have it, yeah?
No, so we don't have it yet. Yeah.
And in emergency situations, I just go for auto-regulation and I forget about gases for some time until I do my first blood gas actually. It's
Yeah.
really amazing. And then
Yeah.
we do a lot of, cyanotic congenital cases where we go with normal air, 21% oxygen. But sometimes with the manual blender, you are either too little or too much on oxygen. But with the QVM from Quantum, it's really nice. You just set up what PCO2 and what PO2 values you want, and then you just forget about everything and just initiate bypass. And what I have noticed actually, the numbers are really close to the blood gas results. So it is something I can really rely on um, during my bypass run.
Yeah, I will add in our hypobaric oxygenation trial that we did, the average arterial PO2 was 104 millimeters of mercury. And it was very precise around that point. You just set it and let it
Mhm.
manage it itself.
Very interesting.
All question finished. No more questions from the audience.
I think we said thank you so much. The great session, and especially thanks to the moderator for managing all the such informative presentation and talk.
Well, George,
Well,
you think about making a visit to the Gulf region, and we can share experiences together.
Well, I would love to do that. I think you all are doing amazing work there and continue to, embrace technology and continue to learn. I think that's my lesson to people after 43 years as a perfusionist is don't ever stop being a life learner.
Great.
Exactly.
Thank you so much, George.
Thank you.
Thank you
Thank you,
so much,
George.
George. Thank you so
You're
much.
welcome.
Thank you
Thank
for
you.
all of you. And thank you for the team that prepared this amazing webinar. And finally, thank you for our great audience, and hope to see you soon in a great time.
Thank you all. Bye-bye.